early.
Good morning, Doctor.
Good morning. Do y'all have any questions while we're waiting? We've got about 5 minutes before class starts. Any questions from before, things like that? Questions about exam? No. Wow. Just so you know, we've got these last 2 slides to finish of Unit 6, and then I'm going straight into Unit 8 with SDGs, just so if you're pulling information together and like your files together, I know some of you do that. So the other thing I will tell you is, since you all are being quiet, not asking questions, is I've been told your final exam is going to be January 24th, is what I've been told so far. Okay, and it's still scheduled for online as far as we know. So just to let you know where kind of that's going. Today and next week will be our last 2 lectures, and we will finish the SDGs, and that's the end of the material. Okay, just to kind of fill in the gap while we're all sitting here waiting. Hey, Gizzy. Hey,
Doctor, all the chapters that you have given us is going to be with us in the final exam?
Actually, your final exam really focuses on, there are going to be 1 or 2 questions that are related to incidence, prevalence, that kind of thing. Not necessarily hard calculations, but more and I can't do it, but I will give you scenarios and say, the rate was this, what rate is that? So you have to know how to calculate to figure out what rate I've given you. Just to make sure, because those are concepts that will never leave you. Everything else is from health transitions forward.
Okay, Doctor, thank you.
Oh, you're welcome. I'm happy to address that. So basically, it's all new material except for 1 or 2 questions, which is really tied to being able to understand rates still, since we use rates to make all our policies. As you're finding out, hopefully you're like going, yeah, they kind of use all this stuff all the time. I know a couple of you were it was really exciting. As soon as the new website came up for MOH here, sent me the link to the new website. It's the same link, but the new content and the new looks of the website. And I thought that was really funny because we had been talking about in class, one of the side benefits, while COVID has been detrimental, one of the benefits to Jordan has been its forced better communication electronically. And boy, you're now seeing really a new website, and it is exciting and stuff. I'm going to go ahead. We're almost at 9 o'clock. And turn on the camera to start recording. And let's see, what else do we need to do? I've got the screen shared with you all. Again, we will do the hour and a half with no break. So I'll finish at about 10:30. I think everybody's had a positive, the feedback I've gotten has been positive, put it that way. So I will continue with that and stuff. Last time and last week, we were finishing up Unit 6, and we had talked about specifically the different, Kissy, stop. We had specifically talked about the different institutions that are here in Jordan, and then we had talked about the impact of the Syrian refugees. And a lot of those numbers on the Syrian refugees, guys, I don't want you to memorize the numbers again. Like I said, memorization of numbers just proves you can memorize really well. But what I want you to understand is what's happened. And you can see how the impact on the healthcare system Jordan has taken on as a result, from shortages in doctors and nurses to different infectious diseases that they had effectively basically ended in Jordan coming back. and things along those lines. So we see these changes, and that's what's really important. The same way we saw that the refugees were predominantly young adults and children, so it kept the broad base of the population pyramid and kind of slowed Jordan down in that transition. So those are the things that you really want to walk away from those numbers, is that, again, big picture of understanding and how it's relevant to the healthcare structure. The last two slides that we didn't have time for are really talking about Jordan and the healthcare private options. Okay, we had done a lot of the government and everything like that. These, again, this is kind of, to me, is interesting for your perspective, because when we talk about this, if we look at that, do you remember, consists of about a third of all hospital beds in Jordan. There were just over 3,500 government beds at the time. Now, we do have all the new field hospitals, which have been opened in the last week or so, couple weeks. But again, field hospitals are a different kind of structure. They're not designed to be a typically permanent facility. And if you read the news and Roya and other things, they very clearly talk about those field hospitals are designed to move the COVID patients out of the general hospitals into it, so the hospitals can go back to taking the normal patient load and dealing with the normal healthcare issues they have. But when we look at the private option, about a third of hospital beds in Jordan come from this. So if you think about this, add another 1,000 or so beds that come from private facilities. That's why they went out and started reaching and doing Defense Order 23, is because they knew they had more beds if they could go that way. The other thing I find really interesting, and it's, like I said, an interesting perspective from your all's point of view, is that more than half of the physicians here in Jordan are actually, and you see this 61%, are actually coming from and employed in the private sector. So they're not working for the government facilities. We're talking about the other thing, it covers about 10% of the population. So what's interesting is while it employs most of the doctors, it only covers a very small percentage. Okay. It only covers a very small percentage. There we go.
So mute.
I've got it. So it took me a minute to get the mute to work. Okay. So what we're looking at here is it only covers a small percentage of the population. In other words, most of the Jordan, and remember, about half of the Jordanians were running through the civil health insurance and MOH. Okay. So this is a small, but what's very interesting, and this again gets into cost and access. Remember those, and the quality components, those three pieces of the triad. And what we're looking at is it covers about half of all health expenditures are now in the private sector. Two reasons. Cost. It's not that what they're doing more work, because you can see they do a small percentage of the work and stuff in the region, but they are charging more. Okay? And that private cost is out of pocket and things along those lines. And it's also drawing on medical tourism. Remember, the government put that option out there as something they wanted to target, but they haven't been affected. So the private sector kind of came in and has a small niche market, I think especially from Saudi Arabia still, that comes over here for medical tourism, if they're not going to Europe and other places. So these are just kind of showing you all of these structures kind of go together when we look at what's changing in the healthcare system. Now, I don't know why my screen's not moving forward. Let me see you. Right. Yes. Why are you not popping forward? Okay. Oh, that's the last page. That would probably be why. Let me go back then one page and say, why is all this happening? Okay. I knew there were two slides. I'm sorry. I started at the end slide and stuff. So that's kind of the private. why are healthcare costs skyrocketing in Jordan? And this is actually not just in Jordan. This is around the world when we talk about fee for service is one of those things that actually encourages unnecessary tests. Gizmo, stop. Thank you. Now, when I talk about fee for service, we are talking about somebody that goes to see a healthcare provider and the provider tells you it costs this much money and you pay it right there out of your own pocket. That is what we call traditional fee for service. What is most people have is an insurance system that we pay insurance now, and the insurance costs are what we typically see coming up. Okay, so we don't pay the full cost. That's very different. But fee for service, and guys, I'm getting a lot of feedback this morning. Can you make sure if you're not talking that the mics are on mute, please? Thank you. And stuff, because I am getting a lot of reverberation here. Besides Gizmo talking and stuff. What this does is it allows you access to anybody. Gizmo, stop. You just want treats. I know what you want. You want treats. Okay. And I apologize on the distraction of my thoughts with this. Let me get a few of these out of here. And what we're talking about here when we talk about fee for service, like I said, is where you pay somebody. This allows you access to any type of doctor. And doctors can run unnecessary tests that aren't necessarily required. So typically we have gatekeepers. And I think we mentioned these last week, and a student had actually talked about it and made a good point that we talk about gatekeepers. Gatekeepers are designed to keep costs down. In other words, you start at a lower level, like a general practitioner, and seeing them. Then if you need a specialist, they will refer you to a specialist for necessary tests to avoid this kind of costing. We also can talk about the demographic changes. And specifically in Jordan, we can talk about the refugee impact. Okay, and that does definitely change why you've had more healthcare costs. You have a bigger society, and with an extra couple million people, it definitely costs more money. The next thing is more of, while it exists in Jordan, it doesn't have the same implications that it does in Europe and the US. And I am sure Dr. Iman in ethics has talked about negligence and malpractice and those things. Well, here we're talking about what I want you to learn and really know is the concept defensive medicine. All my guys, and I see a hand, but hold on. All my guys, okay, what we are looking at is, remember, offense and defense in sports. Girls, I hope you know this as well. Okay, defensive medicine is the same thing as the defense on a sports team. In other words, you start as a physician ordering things to avoid being sued. And again, this is that unnecessary cost component. So we start ordering things and tests to be run because you're afraid the patient, if we don't do everything for them, you're afraid the patient may sue you later for malpractice. Okay? And that's a term called defensive medicine. And it happens very much in the US and Europe especially, that doctors end up ordering, they may think it's one thing and they would need these couple of tests. But just in case, let's order this big slew of tests and labs and other things that cost money to make sure we don't miss anything. That's defensive medicine. Mohammed, your hand is up. Yes. No. Okay. And so that's that piece. Now, the other thing is that technology costs money. All the new equipment, all the new things we have, MRIs, CAT scans, heart transplants, they're very expensive. And so technology developments, as well as even when I say down here prescription drugs, think about all the money that went into all these different companies now looking for a COVID vaccine and how many people they have working on it and all the different technologies and equipment and testing that they need to do. Look at my healthcare costs have gone up, and part of that is also because of technology. It doesn't come cheap. The last thing is administrative cost. And this I want to tie in just for the last point, is really related to having multiple healthcare systems. When we have a universal healthcare system, which is Jordan's goal, remember, what happens is we get one set of paperwork for everything. The same way when we talk about the unified healthcare system. Oh, and Gizmo's making his debut in the corner. I see. Hello. Now, what we're seeing when we talk about administrative costs is in the U.S., and we're even here in Jordan, because you have a private payer system, you have the civil health insurance system, you have all these different components. Each one has a different type of paperwork and administrative cost of how, while the diagnostic codes are universal, how they do it, how they process it, what's required, the different operational decisions, you remember that term? Okay, all of these vary, and that raises administrative cost. You need more people to know how to navigate between the different systems. It's like you have to have translators almost that can understand how to move things between the systems, and so their administrative costs become more. If you have one system, everybody's on the same page and everybody knows what's going on. So these were kind of the key points I wanted to bring up when we talked about Jordan's and where they're going, and kind of concerns when we talk about policies, that we're always still addressing that core component of access, quality, and cost. Okay? Now, if you also remember, what we did is we identified that Jordan has, I just totally lost that Jordan actually, what they've done, waiting for my screens to move, sorry guys. They actually adopted what we call the WHO Sdgs. Remember this? In the 2016 to 2020 Jordan panels, what they did is they said, okay, Jordan doesn't have specific goals. Remember, they were those nice kind of ambiguous goals. We want better quality care. We want this kind, we want maybe a universal access system. But it doesn't say how we're going to get there. It's not specific. Remember, even when they say universal healthcare system, they said within what we can do. So you go, and what is it you can do? Can you do anything? Can you do nothing? Can you do everything? Where is that spectrum? So they came along and said, we'll adopt the WHO's SDGs. So like I said, our last two lectures, to the rest of today and next week, will be on these specifically. So we're going to talk about the SDGs. The SDGs are the Sustainable Development Goals. Mohammed, your hand is up.
Doctor, in the last slide, Doctor, when we talk about administrative cost, how we can determine that the one country wants more healthcare systems than another country?
It's by reading about them. Just that's, I'm not going to ask you about all the different things in that sense, but you do understand that when we kind of go through this, the U.S. is the only developed country, technically the only developed country. I'm getting all sorts of weird mess. Sorry, everything is kind of going wrong this morning. My apologies for my distractions. The healthcare cost of other countries, the U.S. is the only one that doesn't have universal health care. When we look at all other developed countries, technically, that fit in that format, especially Western Europe, they all have universal health care. This has been the downside of the United States. We have tied our health services to employee benefits, and getting our health care through our work. Jordan has kind of done a hybrid between this, and they're moving towards a European model, which is really, to me, very encouraging. But they're not, they still have all this private component. And the private component is what gives us multiple systems, because every different insurance agency that you work with has their own set of paperwork for how they handle. It has their own negotiated cost for what they pay on those services. So everybody is different, and that starts to elevate costs, because when you've got 20 different things going on, I think it's like going to someplace where you can get different types of foods and meals. That restaurant has more expenditure costs because they're doing all sorts of different things. Does that make sense? Than just serving one thing.
Yes, yes, doctor. Thank you.
Did I answer the question okay, Mohammed?
Yes, doctor. Yes, thank
Okay.
you.
Making sure that I didn't get too off track from what you were trying, because I know I got distracted. Okay? Is it Hanan? Hanan?
Yes, doctor.
Hi.
Hi, doctor. Doctor, I want to talk about SDG. We talked about this in last lecture. We talked that it is a sustainable development goal. It's a global goal, our collection of 17 interlinked goals designed to be prepared to achieve more and better sustainable future for all. It's set in 2015 by United Nations General Assembly and intend to be achieved by 2030.
Yes. Yes. And we're going to go through these specifically now. We're not going to, I am going to show you all 17, but we're going to focus mostly on 2 or 3. And really, goal number 3 is the health goals. So we're going to spend most of our time talking about those specifically.
Yes. Thank you, doctor.
Excellent. You're already ahead. That's wonderful. Thank you. And Mohammed, another question?
Hi, doctors.
Hi.
I want to ask you what is the number of this slide, because I don't find it.
It should say Unit 8
It's new lecture.
SDG.
Okay. Thank you.
Okay. So that's fine. Oh, wow. Okay. Lovely. So, sorry, did you find it?
It's subject 3, okay?
If I open your folder, and I go back, let me go back into Teams. Come on, baby, give me that window. It's not going to open. It is definitely, and I think it says SDGs 8. Or if you look at the top of my screen, it's actually labeled as HP SDGs 8-220. So I would assume that's how it's sitting in your file, because I just copied my file into your folder. Okay?
Okay.
You got it?
Yeah.
Yay! Okay. So this is our SDG, and we're going to talk about, like I said, SDGs are Sustainable Development Goals, and they were developed by the World Health Organization. Now, what is the moral or ethical duty? When we look at this right now, what we are talking about is we are looking at the rule. I want to come to this, and this morning when I was looking at these slides, I was trying to think of the best way to say this. How did we come to the SDGs? This slide is more about explaining kind of why SDGs exist. It's not something to memorize again. It's just telling you that we kind of came to this based on a couple of different concepts. The same way as a medical student, when you graduate from medical school, you take the Hippocratic Oath, and that is to what? Do no harm. The SDGs kind of came about based on these basic couple of concepts, and one of them is what we call the rule of rescue. Like I said, the Hippocratic Oath, we're really talking about do no harm, and what we're talking about here with rule of rescue is what we're talking about is, it says that is a perceived duty to save endangered life where possible. So if you think about this, when we're talking about global health, how do we do things that will help save lives? And what are the biggest health issues that we face universally around the world? What are the commonalities we have? What are the things that are important? Is it moms dying during childbirth? Is it people having access to health care? Is it emergent care? Is it vaccines? So this kind of comes into that component. The next part that kind of helped influence it is what we call bioethics, which I know you're doing with Dr. Iman, which is the research regarding international obligations to health inequities. Who has access to what? Do you have the right to choose care? What are our international obligations to other people of having less access to care? How do we go in? Think about the NGOs like Doctors Without Borders. Think about the UN. What are our obligations to people that have less resources? How much can we take in and set up? And what do we need to provide versus what we consider a luxury to provide? Okay? And then think of it from this perspective. And again, go back to those things. So one is looking at bioethics kind of looks to me at quality, okay, and cost. And then how do we meet the needs justly if we can't meet them all? And that's talking about access. In other words, what's the best way, if we can't meet everybody's need, what's the best way we can meet most people's needs? And that comes into the theory of greater good. We may not do the best benefit for every single individual, but what is to the benefit of most individuals? So these were kind of the guiding principles when the WHO sat down and said, okay, this is what's guiding us. Now let's figure out the specifics of what we need to address that will help us with these components. And Mohammed, your hand's still up. Is it up for a new question?
No.
Oh, okay, just making sure. And so, because I saw it out of the corner of my eye. Excellent. What I'm going to start with is I'm going to back up a second, because what I want you to understand is the SDGs came about as a result of what we call the Mdgs. And you're going, oh my God, all these initials, Dr. Heather, no. Mdgs was the Millennium Development Goals. The Millennium Development Goals only had 8, okay, and they were really health related. All 8 were health focused, okay, and as a result of those, they kind of had started to go, these are the things that were the most important health issues. Obviously, the Millennium 2000 came and went. As a result, they decided they needed to update it. So that's where the name changed to Sustainable Development Goals. And then they changed to 17 goals. A lot of them, and only one is solely health focused, which is goal number 3. So if I back up and tell you kind of this is where SDGs started to be formed. In 2015, we had to look at what had happened with the Mdgs. And based on what we were seeing change there, we developed the SDGs. So what I'm going to show, this says as of 2015, this is kind of where globally we were. From 2000 to 2015, we were really effective at decreasing poverty. And what we call extreme poverty actually is a definition. Extreme poverty here means they're living on the equivalent of less than $1 a day. Okay? I can't even imagine. This is one of those concepts that just is beyond me. $1 a day, that's $30 a month. And think about that over 12 months. That's, $500 a year maybe. So we're talking this level of extreme poverty had declined by 50%. We cut it in half over those 15 years. Now, the thing I want you to think about is while I'm throwing out these numbers to you, is these numbers have continued to go down. 2020 would be the year we would expect a new update from the WHO specifically to these guidelines. What's going to happen in 2020 is we're going to see a big influx, because while they had continued to go down through 2019, this last year with COVID has upset that poverty balance again. So these numbers will shift again very dramatically just based on this last year. We may see a little increase again in poverty, and that is because of COVID. Okay, losses of jobs, economics around the world is impacted countries. Okay, so the number of people, then they had the number of people living in middle class. And technically, they define middle class as an average in developing countries of making more than $4 a day. And that tripled from less than 18% of the global population to about 50% in developing countries. So we're seeing quality of life go up in developing countries. And the other thing we started to see is that there had been an increase when we from 83 in developed to 91%. I'm actually giving the literacy rates here. Okay, so people around the world, and remember, Jordan from the 1970s till now went from a very low literacy rate to having one of the highest literacy rates in the country. Okay, come on, you can come up. Oh, okay, and stuff. So this is a shift. So as more people are educated, we can have better materials for people to participate, to read, to educate. When we talk about health education, things like that. So this is just showing you some of the things, kind of the starting point of where the SDGs were. Sarah.
Doctor, I wanted to ask, what does this have to do with the SDGs? Like, is this the reason why we developed them, or?
This is exactly what, and what we started to do is the SDGs, remember last week when I talked about Jordan's goals and them not being specific and them not being measurable?
Yeah.
You're going to see as we get into this, notice that all of a sudden I'm starting to introduce numbers, okay? And these numbers are very specific, and they're designed by the World Health Organization, okay?
Mm-hmm.
And so these Millennium Development Goals, we started to see what we had changed. And so this was the start-off point of kind of where the SDGs start, okay?
Yeah.
Does that answer the question?
Yeah, it does.
Okay, because we're just about 2 slides away from starting to see the SDG actual goals. I see another hand. Hanan.
Doctor, now we're talking about Jordan information, but I don't understand it. We talk in 1917, Jordan have something, but I don't understand what thing. So please repeat it.
Literacy rate. In the 1970s, Jordan's literacy rate, people that were able to read, was a very low percentage. And from the 1970s, over the last 50 years, you now have one of the highest literacy rates in the world. You're at what, 98.6% of your population is literate and reads and writes. And when we have that ability, it opens up doors. Remember, reading is about being able to educate and being able to educate women, especially when we talk about equality and gender, things along those lines. So that's what we're talking about. That's what that was specifically about. Yes? No? You still there?
Yeah, I understand that Jordan have ability to read, and it's very important for women, but I don't know about this percentage.
Okay. I'm not going to ask the number percent. If you go back in some of the slides of Jordan demographics previously, it shows the Jordan literacy rates and things along those lines. So what we're trying to do is think about this way, Hanan. What I'm starting to do is try to tie everything together. Why did you learn about certain policies? Why did we learn certain terms? What are policies? And now we're coming into the specifics of Jordan has said these are going to be their policies. Now, remember, they're developed by the WHO, so they are global policies. So when I talk about this, but Jordan recognizes that they fit the profile and they can use these policies as their own.
Okay, doctor.
Does that help?
Thank you. Yeah.
Okay. So what we also knew is in 2015 that there's still, guys, a lot of gender inequality. Women on average around the world earn about a fourth 25% less, or a quarter, less than men for the exact same work, okay? Climate change and environmental degradation continues. And what's really interesting is it typically affects the poorest people. While the people that cause climate change are typically the wealthiest countries based on technology and use of different fuels and things along those lines, the impact is on the poorest of them. The other thing we start to see is that there are bigger gaps. While we saw this increase in middle class in developing countries, we also see a change in the gaps between rich and poorest in developed countries. In other words, the rich get richer and the poor get poorer. And in developing countries, we have, especially in the United States, we have seen this economy gap grow. In other words, and especially with COVID, they talked about now something called a K recovery. And if you think about the two letters on a K, okay, the rich are getting richer and the poor are getting poorer as the lower part of the limb comes down. And that's exactly what we're concerned about. We still know that there's human conflict around the world, whether it's Syria, Lebanon, places along these lines that are here in this part of the world as well as other places. I'm going to get through this slide and then I'll answer the next set of questions. I see a couple hands again. The next thing we know is that on average, about 16,000 children die around the world every day under the age of 5. Okay, remember child mortality, that bottom part of the pyramid. And so it's narrowed for a lot of countries, and we're better at this, but it's still 16,000 children every day die around the country, not around the country, around the world, okay, before they reach the age of 5. Another thing that's really hard to recognize, and I know here in Jordan it's not talked about and it's less prevalent, although recently you all have had quite a few reported cases for the first time. When we talk about HIV and anti-retroviral therapy, that's what ART stands for. Anti-retroviral therapy. Okay, anti-retroviral therapy. That is the medications used to treat HIV and make it a chronic condition. Just over a third of those around the world get this medication. It is something that when we talk about the United States and other countries, Brazil is really interesting because Brazil many years ago had such a high HIV rate that their government went in, and part of the medical insurance is anybody with HIV gets this therapy, gets these drugs. But if I go into Africa, where there was a large percentage of people with HIV, most people couldn't even begin to afford it. The treatment for the ART drugs cost more than they make in a month, and things like that. So we have problems with people getting the medication. And still, even around the world, with all the progress we've made, only about one in three still lack access to proper sanitation. Here we're talking about clean water, is basically, and plumbing, those basic things that we have come to kind of expect and really want in our lives. So these are still the things. So if we look at this, remember the philosophy, the bioethics, the rule of rescue, kind of develop the mindset of we need to have access for universal care. And how do we reach the people of the world and help their health? To figure out what's important, we have to know what are the health issues around the world. And so the Mdgs and where we are right now, these numbers started to tell us that these are the issues that are important, that we can talk about as a global society. Okay, so we're talking about access to medications. We're talking about childhood deaths. We're talking about access, difference between rich and poor. We're talking about the impact of environment on things. We're talking about gender equality. We're talking about proper sanitation. So these are going to be the things that develop our SDGs, okay? And there's one more set of health equities that I want to kind of go through. I see the hands. Daifala.
First of all, good morning, doctor.
Good morning.
Doctor, since you talked about that there's a huge gap between the rich and the poor, the rich gets more richer and the poor gets more poor. Like, from what I know, that there's, like, for example, Jordan has, like, developed criteria for that situation for helping the poor people, for like giving them at least a bit of an insurance. Yeah,
And
but doesn't like the US, even though it's a developed like it's more developed than Jordan, it's wider and it's like has a huge range like of job varieties and chances of people like to get a living. Doesn't that mean that they could have done the same way in which they could have improved their case of poverty and homelessness better than Jordan and like worldwide?
oh, oh gosh, yes. This is where we get into the politics of the United States. Um, Personally, I think yes. Um, when the United States has done well, we have leveled the playing field. Unfortunately, the politics of the last 20 or 30 years have really been Republican driven. And I'm not going to say I'm pro this or pro that, but their whole philosophy is that if we make the rich richer, they have what they call trickle-down economics theory, which says if the rich can make more money and we take off regulations and let people that own businesses, they will pay the people that work for them better. We actually know that's not true. We also know that when we remove regulations, people stop doing what they need to do. Businesses, unfortunately, a lot of businesses, not all, but businesses end up being about making money. And when they have shareholders, it's about making money for the shareholders. And what do? They pay outrageous salaries to the top echelon of their corporate structure. And the people that do the basic labor work in these companies get paid close to minimum wage, which is not even what we consider a living wage in the United States for cost of living things, like apartment or roof over your house, having transportation. We have done a very poor job at that. The Republicans have done very well at saying that by doing that, they throw the fear of what they call socialism. And European countries have a socialistic view, but it's also a capitalistic view. There is a happy marriage between those two things, or can be. Remember when we looked at quality of life, we find that quality of life in European countries, they have less stress and are much happier than Americans in general. Okay? And that has to do with the fact that while they take less money home, they're not worried about their health insurance. They're not worried about their children's education. Those are things that they pay large taxes for, but those taxes cover those things. So they have a more balanced playing field. And the U.S. continues to expand on the differences and not really draw that equity line. I think at some point we're going to see some major. It's going to totally go in the direction of no access to the poor, and that will be a sad thing. Or else it's going to have to balance out. I think it will be interesting to see what happens with the new administration and if they're able to change any of those policies. But yes, you are correct. Mohammed.
Doctor, I want to ask you if in the United States, the poor people, how he can treat or make it medicine if they don't pay the taxes.
A lot of poor people don't have access to care. And you're going to actually see, if you see on this slide where I was just going to, is it talks about the fact that many millions of Americans don't have health insurance. And what has been very interesting is COVID has very publicly brought about the realization of the health disparities. People that work in healthcare have known this for the last 20 years in the United States, but it's just now becoming something that the general public is starting to see. Unless you were directly affected and worked in healthcare or were one of these disqualified, just somebody suffering from health disparities is how we like to call it. You wouldn't have known it. And now COVID has really kind of, the same way COVID here caused technology and more use of electronic data, here in the United States, COVID has made the general public more aware of these health disparities and that there are a lot of people that cannot survive and do not have access. Just the thing of testing becomes important. So that was kind of it. Let me come back to this slide. Okay, are we okay? Does that kind of help, Mohammed?
Yeah, thank you, doctor.
Okay. You're going to see that here it talks about many countries offer government-sponsored healthcare programs. Like I said, these would be the European countries. This would be Australia, New Zealand, every developed country except for the United States. And here I very clearly say the U.S. healthcare system is the only developed country without universal healthcare. At one point before Obamacare stepped in, we were above 50 million Americans. And remember, our population is 330 million. So we're looking at about 1 in 8 or even less that would actually did not have access or lacked appropriate health insurance coverage. Obamacare brought that down. We got down to about 28 million. We are now back up to about 35 million. So this number fluctuates. But what I want you to understand is there is that health disparity, that large portion of people that don't have access to care in the United States. And when we talk about a pandemic, it makes it hard because they then can't afford testing. They can't afford to be sick. They can't afford time off from work. All of that compounds the issue of trying to make it better. The flip side of it is in the United States, we technically have the highest quality health care and the best medical technology. Like I said, this was, I think, very early on in the semester, I talked about the United States is if you have a heart attack, if you have an emergency care, if you're in a horrible car accident, if you are a victim of burn in a fire, we have some of the best technology and the likelihood of survival is better. We don't have fewer heart attacks. We're just better at people not dying from them. Okay, and this comes to our quality of care and technology. So it is the place for emergent care, but remember, with that technology comes a price. Okay, many poor are relegated to inferior health care system because their insurance is not universal. And that is, again, they can't get access to the right type of care, the quality of care. Now, let me shift to Jordan. The first couple were the U.S. Now let's shift to Jordan. With this civil health insurance, remember, Jordan kind of gives one set of data. The government gives one set of data. And then other people within Jordan give another set of data. What the true number is, I do not know. Okay? You have seen numbers from Jordan that say 50% are covered by MOH. Okay? But then Jordan comes back and says, but 87% are insured. That means that another 35% would be insured through private insurance. But other surveys, when we ask Jordanians if they have health insurance, when we do a survey like that, about 30% say, no, we don't have insurance. So somewhere around 2/3 to 3/4 of Jordanians have some type of insurance, whether it's through work or privately bought or through the government. So that leaves still about 1/4 of Jordanians that don't, okay? Like I said, the numbers vary, but just so you kind of have a broad picture. Again, in Jordan, where they're lacking is health is not a constitutional right. It's a desire, it's a goal, but it's not your right yet. Okay? And the last thing is that mental health services are lacking. And here I'm probably not telling you anything new when we talk about the cultural component of mental health issues in the Middle East. Okay? So, that being said, and I'm not going to spend any time on this, I just wanted to show you, this is kind of the WHO's map at the time. And the WHO kind of puts people in pockets. And you're going to see various maps. And typically, when we talk about Jordan, we're talking about what they consider the MENA region. The Middle East, North African region is how it's typically grouped and gathered. So these are just kind of showing you different areas and different color maps. And they kind of populate this little area of the world together. Okay, and stuff. And then we've got Europe, we've got North America, we've got South America, we've got Central America, we've got Australia, we've got Russia and China. So you can just kind of see the regional groupings. Now, what I do, so when we do these groupings, think back to your population pyramids, and also think back to the demographic transmission models. What I'm going to do is I'm going to blow this up. The first picture is life expectancy. Second picture is infant mortality, okay? And when I blow this up a little bit more, I'm going to slide over so you can see it. If we come back in here, this is going to be Israel right here, the little dark dot, which is out of pocket with the rest of the Middle East. Okay, we come back in here and we can look at life expectancy at birth. Notice that you're kind of in these middle greens, okay? If we look down here, life expectancy somewhere from mid-50s to late 60s. As we get into the darker colors, you see higher life expectancies, and we get into these really light colors, we're seeing much lower life expectancies. Okay, think about that. With low life expectancy, where would you be on the population pyramid, or where would you be in the demographic transition model? You'd be in somewhere between stages 1, most aren't 1s, but 2s, things along those lines. As we get into these greens, we get into the 3s and 4s. And as we get into the dark colors, really dark colors, we have these really high life expectancies. Think about those. Japan, what do they have? They have an inverse model. Okay, the United States has a higher life expectancy, although it's been dropping in the last few years. Australia. So you start to see Europe. You start to see how these fit the patterns. And if I scroll over now to then the birth rates, so high life expectancies, look at the same countries that had high life expectancies, and what do we see down here? We see, Gizmo, I can't see. We see low birth rates, low birth rates, low birth rates. Do you start to see where all of these patterns are all fitting still the same? What do we see down here? The darkest colors, where there's low life expectancy, have the highest birth rates. Okay, we see higher birth rates in this area. When we come into the Middle East, we're still seeing higher birth rates than we would in certain other areas. Okay, they're not as high here, but they're still high. And some of that is more cultural. Okay, so this is kind of what we start to see is the differences of patterns. So you can think, oh, stage 2, stage 3, you start to see, oh my gosh, they've put all these together to explain those models. Now, so when we look at this, let me come back now to getting it into my screen. Come back up. Now we can talk about the SDGs, okay? And if we come in here, these are the 17 SDGs that came about. The first one is look at poverty, look at hunger, okay? Number 3 is the one we're going to spend a lot of time on. We're going to see the details within it. Good health and well-being, that's our forefront. But quality education, notice gender equality, clean water and sanitation. We can talk about having economic growth, having industries, reduced inequalities. Come down here, we can talk about climate change and land on the life, and we talk about social justice and sustainable cities and communities. So you see how the SDGs are dealing with this ideal of creating a global society that really is to the benefit of the world. Okay? But like I said, and I'm not going to ask you to memorize all 17. Again, that's just memorization. What I want you to see is that they're all dealing with these. What you definitely need to know is these top 6. Okay? Poverty, hunger, health, education, gender equality, and sanitation. Just makes sense. Where we're going to spend a lot of time, though, is we're going to spend time looking specifically at the WHO said, well, what is good health and well-being? That would be kind of like saying I want quality health care in Jordan. They've now come in, and under each one of these goals are very specific, measurable things they want to see happen. Okay? And what you're going to see is when we come down here, I know I've just popped a couple slides past you. Before you ask the questions, we're going to come in and we're going to see exactly what these details will be. Okay? So bear with me. We're now going to start to move into the details of the SDGs. But the first thing is we're going to come back to NCDs. And almost all of the SDGs, when we talk about health, have to do with non-communicable diseases. Okay? And probably the most important thing I can talk to you about right now is obesity is a disease, is now classified as a disease. For a long time, it was not classified as a disease, but a condition. Okay? And obesity, we know, is linked to all of these different NCDs, from heart disease to diabetes to stroke to cancers to respiratory diseases. And when we talk about the Middle East specifically, when I do the endocrine system with the third years, I spend 2 hours and all I do is talk about diabetes in the Middle East. Okay, it is one of the biggest issues. Genetically, you have a predisposition for type 2 diabetes. And then as you adopt a Western lifestyle and diet, it increases the risk dramatically here. You all have rates that are higher than most parts of the world for type 2 diabetes. Okay, and type 2 diabetes is also associated with obesity. When we talk about obesity, if you remember last week when we looked at Jordan, Jordan has one of the highest rates for women with obesity. Okay, about 41% as we age and stuff, and it's increased. And the thing is again, do you remember when I was talking about the 3 health issues that we've gone from? It used to be infectious diseases were developed countries, NCDs were developed countries, and then we said, nope, guess what? 4 countries are having to deal with infectious diseases, NCDs, and mental health issues. So when we looked at all of those and combined, what we have also found is that low-income countries, because they start to adopt a Western diet and Western lifestyles of being less physically active, we start to see type 2 diabetes increase in every part of the world. Okay? So these are typically, if it was not the year of COVID, these would be the health issues. Do you remember also last week when I was talking, and we looked specifically again, we went back and we looked at the deaths in Jordan and noticed that most of them, except for the road traffic accidents, were all NCDs. The thing that came along this year and bumped up and slowly went to number 2 was COVID, okay? But otherwise, this would be the topics we're most focused on, okay? So that's why this year we spent all our time talking a lot about COVID and less time talking about NCDs. But NCDs will be here once everybody is vaccinated, and we still are dealing with other issues. Izzy, you're really not doing this well. Thank you. So let me blow this up. And again, this is just a poster that the WHO put together, and I think it's lovely because it, again, starts to talk about the global health status of NCDs, okay? And if I come over here, you're going to see it accounts for 38 million deaths every year when we talk about the global health issue. 74% or 28 million are in low and middle income countries. This gets back to that point that I brought up when we started about the health transition. It all of a sudden, guess what? It's not just rich countries, it is all countries. Okay? Half of non-communicable disease-related deaths are caused by cardiovascular disease. That means 50%, doesn't it? Okay, so around the world, 50%. In Jordan, when we looked at cardiovascular disease, what was it, like 36, 38%? But when we look around the world, half of all deaths are related to cardiovascular disease. We can talk about cancer, diabetes, and chronic respiratory diseases. Notice this is the other 4 of the triad, or not of a triad, but of a nice little loop of the common diseases. What are the 4 shared risk factors? I love this part of the diagram. It's my favorite part. Notice the cigarettes, so smoking, obesity, diet, and alcohol, okay? And they say physical inactivity. Physical inactivity leads to obesity, and we see the little fat man, okay? The World Health Organization has called for a 25% reduction in premature deaths. Sorry, deaths is cut off here. You do want to know that. In other words, this is a measurable goal. So we want to treat NCDs. Part of the Sustainable Development Goals says we want to treat NCDs so we reduce preventable deaths and premature deaths by 25%. Okay? How do we do this? We're going to measure case fatalities. Okay? One of those rates you learn very early on. That's how we're going to know if we start to reach that goal. Izzy, can you get down, Nate? Okay, thank you. So this is where we start to look. Okay? Now, everybody okay so far? You're going, oh, this is it's not as bad as you think. It's actually really kind of interesting. And it's definitely different than talking about COVID that we've done so much recently throughout the semester. So let's go in, and then they break down. So we've identified the big health issues. Now it says let's have common global targets. Remember, it's 2025 and then ultimately 2030. We've kind of given ourselves 5 years wiggle room. Izzy, I let you down not to go bark at the window. Hey. Okay, so 25% reduction in premature mortality, which is just where that poster ended. You notice that's right in the center of this diagram. So that how are we going to get to that 25%? Well, let's break that down into smaller things we can talk about. And so that's exactly what they do. And again, I'm going to blow this up as good as I can. And I'm sorry if I go any bigger, really, it kind of gets blurry. Okay, so let me see. And we're going to come over here. We're going to talk about, and I'm going to start with the heart. So we can think about, what are we thinking about? At least 50% of eligible treatment receive drug therapy and counseling to prevent heart attacks and strokes. So what are we going to do? We're going to start giving people statins. We're going to give people aspirin as a blood thinner. At least 50% will get medications that help prevent heart attacks, okay, and strokes. So while they have heart disease, we're not going to let it develop to the worst level, okay? We are going, so that's one thing. Now, down here, I see a hand, and I'm going to ask a question in 1 second, so I'll get the hand in 1 second. The next thing says, halt the rise in diabetes and obesity. What does the word halt mean? Okay, there are more than 200 of you here, which is great. One of you can tell me what halt means. What does halt mean?
Stop.
Exactly. Stop. And if we say stop, are we talking incidence or prevalence? And notice it says halt the rise. So are we talking incidence or prevalence?
Incidents.
Bingo. So their goal is 0 incidence of diabetes and obesity in the future. That is a huge goal. Okay, it's not saying we're going to stop the prevalence, but we're going to stop adding new cases into our prevalence pool. Excellent. Gosh, you all are good. Okay, now the next thing, so that's another goal that will help us get there. A 25% reduction, 25% relative risk reduction in the prevalence of raised blood pressure, or contain the prevalence of raised blood pressure according to the current conditions. In other words, whatever the measures are. 120/80 was typical. Now some people are doing 110/80 still. It depends on the guidelines. But notice here a 25% relative risk reduction in the prevalence. So that means we're not talking about incidence, we're talking about existing cases. How are we going to reduce blood pressure rates? Can anybody think about this? Are you all, I think you all are just starting to, by using medications. Exactly. Yeah. What else can we do? What?
Exercising, making a healthy diet.
exercise and diet, and specifically what in the diet do we need to reduce if we're really
cholesterol intake.
well cholesterol,
Sodium.
sodium, your salt in your diet for blood pressure. Exactly. So these are things, so we're going to talk about those pieces to help us reduce the prevalence. So while they are still, once you are hypertensive, you're doing other things, we're going to reduce the people that are in that pool. Okay? So this is another component. Notice, and that gets close to over here. Then we get over here to a 30% reduction in current tobacco use in persons 15 years or older. Well, we already know Jordan has the highest percentage of tobacco use in the world. Okay, so
Smoking.
so we're going to reduce people that stop smoking. So this is, again, it doesn't, here, it's people who are already smoking. It's not talking about incidents. It's not talking about stopping new smokers, but it is talking about getting people that currently smoke to reduce or come down, to stop. Again, tying with the blood pressure, we can come over here, a 30% reduction in the mean population intake of salt and sodium. Did I follow?
I was asking for, although like you would add those like criteria or regulations and explain to the people, like although it's something that you would inform them about, but it wouldn't be very convincing to their mind. Like at the end of the day, they will be doing that in their own decision, because it's not like a rule. You cannot rule someone, oh, you have to lower your salt intake or you have to reduce your smoking.
That's always been the hard part of NCDs, is remember it's all about human behavior and choice. And if we go back to the very beginning, remember we talked about the examples of having sugar police in the United States, and where he outlawed the big gulps in New York City by Mayor Bloomberg, things along those lines.
Yeah.
This gets into that. This gets into the human behavior component of it. And this is what's so interesting, is Jordan really has a young population. Most of Asia has a very young population. If we could change the behavior in those populations, you won't have the same health issues we have had in Europe and the United States. You all have the advantage of time right now to change having to deal with these health issues. It's how do we do it? Because, like I said, effectively, we can talk about health education, and I can give you the knowledge. It doesn't necessarily, the knowledge does not always translate to behavior. And so that becomes the real crux of the point. You're absolutely right. But notice now that what we've done and what Jordan has adopted these. Jordan's policy is very specific about a 30% reduction in tobacco. This is one that they have made public. Okay, but these are the goals that when they said they've adopted for 2016 to 2020 in their policy, these are the specific things that they are now tracking and monitoring. Okay.
Like after doing their research on what the root causes of the NCDs, or what were the branches of the causes of NCDs that were by the population or the community that is found in Jordan, they have found like, okay, we have like a high issue in salt intake, we have a high issue in smoking. Let's inform the people more. Let's teach them more about it, and let's show them what is better for them to do.
That's the goal. That's the idea. But sometimes, and like I said, what's really happened is that this year everything has been offset. And where I would have focused the whole course to this angle previously, everything has been offset by COVID this year. So we've focused all the health issues. And the thing is what's happening is, remember when I talked about the hospital again in Jordan right now? Their idea is that the field hospitals will become the sole providers of COVID patients. As sole providers of COVID patients, we can then,
focus on the others.
Focus on the others. Because this stuff didn't go away. It's still there. It's just everybody's focus, their eyes are glued to the other.
Yeah.
Yeah. Okay.
Yeah.
You're welcome. Mohammed.
Doctors, I have something to do about tobacco.
Yeah.
When we talk to the people, what is the disadvantages and the negative effect on the health about the cigarettes or anything related. Sometimes they are about it. There are a lot of doctors, okay? They smoke.
I know you.
Because this, we can force people in indirect way to reduce the using this tobacco, such as we can make this price is very high. Over the time, the people, it's very common to don't use much cigarettes, and they can stop it.
Well, like I said, most of the world, actually, in Europe and the United States, they did make the taxes so high that that's what the impact, and it is one of the most effective ways to get a society to stop smoking. Jordan raised the tax,
But doesn't that increase crime rate?
I heard somebody else talking, sorry. But not to decrease the smokers, but to increase revenue and stuff. It is absolutely an effective way. And what's interesting is Jordan has done something very specific. They have not tried to increase the tax on tobacco cigarettes, but they have a 200% tax on vaping cartridges to stop that component. And that has had an impact in 2019, October of 2019, they implemented a law that caused the increase of 200% taxing on vaping. So we haven't seen the same behavior of vaping that we have seen in other parts of the world, which is very interesting. Remember, you all did that survey with me about vaping and tobacco smoke. And I think only about 17% of your class, 17% of your class actually recorded or discussed that they actually use some type of tobacco product, whether it's shisha, vaping, cigarettes, things like that, which is very different. Your class is the first class that's very different and a much lower recorded level than the other previous classes. Mahmoud.
Morning, doctor.
Good morning.
I just asked one question. We can put the road traffic accidents on the NCDs.
Like I said, technically they're not communicable, so they could be, but typically we've housed them now in a separate category, which we call injuries. So traffic vehicle accidents, motor vehicle, boating accidents, drownings, falls, all of that tends to get housed now in a separate thing that we call injuries.
Okay, thank you.
You're welcome. Okay, so let me continue the circle really quick. Okay, so we looked at this. So we've got reduction in tobacco, reduction in salt. Notice here, I love this one. A 10% relative reduction in prevalence of insufficient physical activity. In other words, what are we going to do? We are going to make more people, we want to make access to people being more physically active, taking walks, doing things along those lines. We are not talking about joining a gym. We're just talking about getting people up off a couch, okay? A 10% reduction in the use of alcohol, okay, within the national context. Because while alcohol is acceptable in various societies, here it's frowned upon, but in other societies, we do know that abuse of alcohol does have health consequences, okay? So we want to talk about a reduction in there. And let me just get through this last one. The last one says an 80% availability of affordable technologies and essential medicines, including generics required to treat major non-communicable diseases in both public and private facilities. So here we're talking about access to appropriate medications. So we can be talking about glucophage or insulin if we're talking about diabetics. We're talking about statins if we're talking about cholesterol levels. We're talking about beta blockers for other heart issues. Having those drugs available, having vaccines for kids, 80% at an effective rate and access. So we talk about affordability and access. Again, that triad always plays in my head because you can see how they're trying to balance all of these different things. But these are the specific goals that have been measured out. Mohammed. You okay? Okay. So this is nothing different. Actually, it's just a clearer view of every slide I just showed you. So these two slides are the same. If you couldn't read the first one and you didn't like it, you can come over here. Physical activity, 10% reduction, sodium, alcohol. Notice the diabetes, 0% increase. Okay, so all of those measurable things are just shown to you clearly one more time. In case you didn't see it the first time, now you get to see it the next time. Gizmo, halas. Now, did I follow? I'm going to put you on the spot here because you were one of the ones that brought it. I think you and Mohammed were both trying to tie this, and I think maybe Hanan at the very beginning. This is the slide I didn't want to say anything about because now we come back into Jordan has specifically tied these goals. And you're going, is Jordan really doing this? Yes. Here are your actual impact numbers related to Jordan on all of these. Notice that we talk about alcohol, physical activity, salt, tobacco use, blood pressure, diabetes, every single one of those. Now, there are a couple down here that actually fit in the other SDGs, air pollution and household air pollution. But they have those. And what we have is we have the data was collected in 2016. Again, and you go, but Dr. Heather, that's actually really new data. That's the data because the next impact was, remember, going to be 2020, which would have been this year to measure. So these are the numbers, and we want to see what happens between this set of numbers, and now in 2020, we'll have a new set of numbers, okay? What you do need to memorize. See this top number at the beginning? This is how many lives could be saved just in Jordan over the next 5 years by implementing activities to go towards the Ncds, okay? If we talk about this and we talk about the reductions, and I'll go through it piece by piece, but what I want you to see is we could save almost 34,000 lives in Jordan. That's that premature deaths could be saved in Jordan over the next 5 years if we effectively address the NCD component. That's a lot of lives. That's just here in Jordan. That's not elsewhere. So let's take a bigger look, and I'll scroll it down a little, and I'll see if I can expand it out so we can get the total. Okay, excellent. Now, what we have here is what I want to show. Oops, I'm going to have to bring it back down just a little bit. Sorry. Okay, what we have here is premature deaths from NCDs. Notice the total NCDs, okay? In 2016, we had 28,500 people die from NCDs. That's how many died from cardiovascular disease, diabetes, stroke, all the things. When we look at those top 10s typically of death, okay? Those are your NCD deaths in 2016. It gives you the number of males, number of females. What you notice is there's
في نت ولا لا؟ شو اللي صار؟
وصل عندنا.
في مشكلة عندنا.
يلا خير. فيش بريك شكله اليوم.
You can force people.
شو اسمه مين بيلخص؟
أنا بعد المحاضرة بلخص.
من ايش؟ من فهمك ولا بتمسك كل كلمة حضرتك؟
لا الأشياء المهمة.
Can you hear me?
Yeah,
Yes,
yeah.
doctor, yes.
Yeah,
Okay.
Yes,
can
doctor,
you
yes.
say, hold on. Something went wrong. We're trying to get you back in the meeting. It's beeping at me. Can you see my screen?
Yeah.
Yes, yes.
Yeah.
Yes, everything good.
No, doctor, I
Okay.
can't see.
Lovely. Lovely. Okay, because it's saying I'm getting lots of feedback. It's beeping, telling me problems with connections, all of this. So bear with me. We just had a technical,
No problem, doctor, no problem.
mobile technical issue. Okay. So this is
Dawlat
just
can
showing.
see.
Can everybody see now?
No,
Please
teacher.
share the screen, doctor.
You can't see the screen. Okay, let me stop sharing and try to reshare and see if it will reconnect. Okay.
أنا
لا
مش
doctor, no.
Some said they could see it, some said they couldn't. So let me just reconnect it. Okay?
بس سؤال إحنا أي ساعة بلشنا؟
Everybody good?
Yes, yes, doctor, yes.
Excellent.
Good,
Excellent. Okay. So these are just then giving you the percentages of premature. Like I said, people will die of heart disease. Some will not be premature deaths. So this then tells you what percentage of this number, the 23% of the males, were premature deaths. So notice that we have slightly more males than females dying from Ncds prematurely. If we put those averages together, when Jordan publishes that number, they say 20% are premature deaths for men and women combined, which kind of makes sense when you look at the two sets of numbers. Okay, it doesn't talk much about suicide because suicide is not favorably, is a cultural component here. And so I will let it go at that. There may be more, but they're not recorded and they're not reported. Now, let's come down. And here what they talk about was a national target set. Okay, and notice here that they actually, when they have the X's, it says Jordan has not really set their number. Yeah, we want to reduce alcohol, but they haven't set a number. Why haven't they set a number? Because technically people in Jordan, the majority are Muslim, and technically they don't drink. Now, we know that is not the case because, like I said, there wouldn't be a liquor store every 500 feet if there weren't people drinking. Okay, so there is a supply and demand issue here. But we're not, they don't measure it. And notice here that when even we talk about fatalities, they don't record it. Okay, physical inactivity, again, let's go back to the SDG goal is a 10% reduction in physical inactivity. Jordan hasn't quite said we're going to get there, but they're figuring it out. What they do know is in 2016, about 10% of deaths are related to physical inactivity, and they're attributing about 13% of females, okay, have this I'm sorry, this is not deaths. These are now risk factors. So they say about 10% of males, 13% of females. I would beg to differ that females have a much higher risk of physical inactivity, and that is a cultural component. Again, getting out, going to gyms, exercising, things like that, tend to be just a cultural piece. Now, sodium intake, again, while they don't do it, they measure what is above salt intake. 20 plus grams per day is more than you need. And they say about 10% of each gender, okay? Tobacco use, they did agree with the 30%. But what's really interesting is notice down here, Jordan said, guess what? We don't know what our numbers are. Well, they know what their numbers are now, and you're number one. Okay? But they do have a goal for the 30%. When we talk about the blood pressure reduction of 30%, this is, again, what they are showing who's at risk in Jordan. They're looking at about 16% of the population in total. Again, you can divide it by gender. Diabetes and blood sugar. They think about 13% of the population is currently at risk. I can tell you it is higher than that. Okay? So we have some offset. Obesity, again, they haven't set a specific target, but if we come over here, at least we get better with the numbers. They can look at, again, the 40%, 27%. About a third of the population of Jordan is at risk when we talk about adults with obesity, okay? And notice what's really trending and where it's important is this number is more interesting to me. The adolescent obesity rates. Because if we have poor diet and we're not physically active as young adults, you will go into this population pool. We have about 12% of Jordanian kids that are now starting to fit these profiles. And these are kids that are not active, overweight, obese. We need to target them. They are the future, okay? And getting there. And then they talk about the others. So what we can see from this is Jordan has started to come within these numbers. They have started to try to figure out what is our rates, what are we looking at, things along those lines, and how do we measure these? Like I said, if we adopted and addressed these different risk factors, it would change the mortality rates. And what we're looking at is almost 34,000 lives that could be saved just by addressing these risk factors over the next few years. Now, I am going to try to get us through a couple more slides because I'm definitely behind. Yeah, I'm definitely not to where I wanted to be today. Okay, so let me go ahead. I'm like, how far am I from the slide I really wanted to be at? I'm a ways. I had hoped we'd get to like 27 today. We're not going to get there. Let's now change to the next set of goals. Okay, within this health and nutrition, so the first area focuses, here's Mo. The first area focused on NCDs. The second area that they address within the health area, okay, the health and, so it's goal number 3 still, is we look at maternal child health targets, okay? And so here we were talking about things like stunting, children not growing up properly, being overweight, breastfeeding, wasting. Stunting and wasting are different, okay? Wasting is loss of weight, stunting is prohibited growth, okay? Anemia and low birth weight. These are the 6 components, the same way we had cardiovascular disease and salt and physical activity and tobacco in our NCDs. These are the 6 components of maternal health, okay? And when we come over here, I love this slide. Not for quizzing and for questions. I can promise you I actually have written your exam this weekend. I am not asking you the specific numbers in these slides. Hear me. I am not asking you the specific numbers in the slides here. At least these 6. But what I want you to see is this is lovely. And I like how this is done better than I like the NCDs because it talks about this is our goal. This is what we need to spend. And this is the outcome, the impact and the outcome we will have as a result of that. If we do these things, we can have these things saved. So the overall goal is, when we look at this, is if we talk about stunting, we can talk about 65 million fewer children being stunted, okay? This is by 2025, okay? So 65 million fewer children will be stunted is the goal, okay? If we spend this much money, it will save 2.8 million children's lives, okay? That to me is huge. We are talking about having proper nutrition and access to care for children that will save 2.8 million lives. If we talk about anemia, which is low iron levels that lots of women suffer from, and you hear about it here in Jordan quite often. The goal is if we had $12 billion or almost $13 billion globally spent towards it, we could have 265 million women, fewer million, I cannot say this today, 265 million fewer women suffering from anemia, over the next 10 years, and it would save almost 800,000 children. If we talk about breastfeeding, notice that the cost of breastfeeding is very low. And we're talking about the actual cost of breastfeeding is zero, but we're talking about the awareness and the campaigns and the support that goes to it and pumps and everything else. So if we look at globally spending $5.7 billion, we could save over 500,000 lives. That's a very little cost for all these lives saved. And that means that we're going to breastfeed 100 million more children every year. Okay? If we talk about wasting, we talk about children that are malnourished. And if we talk about $9 billion, we could have 91 million children have better nutrition. And as a result, almost 1 million children's lives could be saved. What they've done across the top is they've said if we addressed each one of those specific goals, it would save approximately 3.7 million children. Those are huge numbers. This is where maternal and child health becomes so important. And these are things that have, when we talk about cost, think about the cost of these things. And while they're in the billions, this is the world. That is so small of an investment, unlike the money that we spend on cardiovascular disease, unlike the monies we spend on the Ncds, which need much more once we get into that secondary prevention or treatment modality. These are all almost primary prevention. They are what we get in return for the money we spend, and the lives that are saved are huge. Okay? Now, I do have, so let me talk specifically about a couple of these. And I've got about 3 minutes left, and then if there are any questions, I'll address questions. Okay? When we talk about breastfeeding, we talk about improved childhood health, and we talk about better health for mom. Do you remember how we've talked about herd immunity? If obviously we're not talking about herd immunity here, but we're talking about passive immunity. When mom solely breastfeeds, she gives her immune system to the baby. And that, while the baby is breastfeeding, when it can't have vaccinations, it's getting immunity from mom's breast milk. We know there is no better nutrition for a baby than breast milk. Period. End of story. And we know that it's good for the mom. It's good for mom and baby because it actually develops bonding patterns that are not seen even when we bottle feed. Okay? As a result, long-term in life, better cognitive development, better learning, higher productivity. We can then say long term, if we have higher productivity, we're talking about better economy, better wages. It's a positive. Now, this is really long term and hard to measure, but we do see this pattern, okay? If we talk about reduced maternal mortality rates, it is the leading cause of death in women when we look around the world, okay? That's the #1 cause of death around the world. The relative risk, which is the risk of dying during childbirth, can be as low as 1 in 2,000, almost 2,800, to as high as 1 in 16. It depends on where in the world you are and what access you have to proper health care, proper OBGYNs, a nurse practitioner or a midwife during labor and delivery, and complications. The leading cause of death when we talk about maternal mortality is postpartum hemorrhage. And when we look at this, we can look at the health disparities between developed and developing countries. Typically, about 34% of those deaths due to postpartum hemorrhage are in the developing world, compared to only 13% in developed countries. That shows you, again, that disparity, access to care, equality, things along those lines. So we come back into this. If we talk about the results, and this will be the last slide of kind of where I stop. In 1990, so this is about 10 years before you were born, Child mortality, and remember child mortality, that means anybody under the age of 5, sorry, my brain's losing it. Under the age of 5 was about 90 per 1,000 children. Now look at the difference. We dropped by 2015, it was cut in half. Remember I talked about 16,000 children still die every day in this country. That's where the 16,000 comes from. But we've dropped it from 90 per 1,000 to 43 per 1,000. Okay, the reduction in child mortality went from 12.6 to 6 million. And that is a decrease in child mortality. Even while more children are being born, the rates are going down. So that's a positive. The other thing we know is that the measles vaccine is very important when we talk about childhood death. And as the country got bigger, as the vaccines around the world, more people get the immunization. I'm trying to see my words. So we're looking from 73 to 84%. Just having more children vaccinated against measles in this age range prevented 15 million deaths from 2000 to 15. And I should have the number there, but I'm not going to ask you what year. So we see these changes and the impacts they have. Okay? Now, where I will start is we will start and pick up with slide number 19 on maternal mortality next week. And hopefully we're going to get through all our slides. There are lots of numbers and statistics here. The Sdgs, like I said, it's where we get measurable. So when you need to know something measurable, like the 30% reduction in tobacco, the 10% in physical activity, yes, those are important. But the little numbers, like all the stunting numbers, you don't need to know the numbers. You need to know the 6 main issues when we talk about maternal health, and that we're reducing maternal mortality. And we've reduced infant mortality by 50%, and it's now 16,000 per day. So that's kind of where you need to go. I know I'm at 10:32, so I will ask, do you have any questions this morning before we finish? Everybody's like, oh my gosh, an hour and a half. It's been a long hour and a half. Everybody okay? I see a hand. Hold on. Go back. Go back. I can't see who it is yet. Just talk.
Thank you, Doctor.
Thank you, Mohammed. Okay.
Honestly, I don't have any questions, but I wanted to ask about the ability if you can remove some subject from the final exam, even if it's 1 or 2 subjects, it will help us a lot.
Before class started this morning, you wouldn't have known. I had about 5 minutes before class started, and yes, I discussed that shortly. There is almost, out of the 40 questions, there are only 2 questions that are old material, and both of them are related to being able to understand rates. As I explained to the few people that were online early, those are not so much about you having to calculate, but you do have to be able to calculate. It's more saying, if I gave you this number and said this is what's happening, what rate is that? So you have to be able to look at the question and understand it. Those rates never go away. So those are the only 2. Otherwise, everything on the final exam is from health transitions forward. So it's all new material, basically, except for 2 questions. How's that? Mohammed.
Doctors, I want to ask you something. The final exam.
That's what I was talking about, yeah. Pardon?
I wish you put it easy, please.
I've already reduced it. It's only new material except for 2 questions. There's nothing more. What are you asking, Mohammed? Because I don't get it still then. Yes, Mo, stop. I don't understand your question then, because it is all new material except for 2 questions, and I told you what that's about.
I ask you, a final exam, it is difficult. It's easy or not?
You're asking me. That's a relative question to every single person. I don't have the answer for you.
Please make him.
That's
Please
relative
make
to
that
every
easy,
single
please.
individual. I can't answer it for you. There is, I will tell you this, because as you can see by the SDGs, I would say there are a few more questions that some of you that like to memorize facts, you're going to like that because the SDGs are basically to memorization. But as far as the health transition, the models, all of that, that is all applied. So it's a combination of the two types of exams. I know you all like those that have more memorization, but it's not all, it's only a few more questions that are more memorization. Most of it's, again, very much like your last exam.
No.
Okay?
Okay.
Okay. Any other questions? No other questions. Daifala.
When we talked about I was thinking about the question mainly just because whether or not I should ask it, but now that I think about it, when we were talking about like the cost of informing people about breastfeeding, the anima, all those type of things that would actually save people's life, doesn't that actually show, as we talked like in the previous unit, the about the healthcare reform dilemma, which is like you only assure two things, but the third one would be problematic. Like we assure care and we preserve quality, for example, for making some charity work and like policies and like not policies like informing people about breastfeeding, for example. But the cost is like $5 billion. It's like it doesn't come easily that amount of money, or is like 69 billion dollars.
But like I said, put that in global terms. In global terms, that's pretty darn, and it's still hard. But that's globally. If we spend that globally, that's how many lives we change. So that's a big. It's doable. I think that's more what I want to kind of get to your ideas. And no, money is not easy anywhere. But if you think about that's so, let's say Jordan takes. That means Jordan needs, a few $100,000 on something like that. That's doable for Jordan. Does that make sense?
So basically, this is like we talk about globally wise and not like local wise
Well,
only.
remember, SDGs were developed globally and stuff. Like I said, Jordan just kind of said, okay, we'll adopt these and they'll be our measurable goals. So these numbers, the budget numbers, come from a global budget. So yeah, so if you think about, okay, 8 billion around the world, how many countries in the population of Jordan in percentage? Then you go, oh, that's not that much money that they're asking Jordan. That's how much around the world. So all of a sudden it becomes more doable when you look at those maternal goals because they are very much more cost effective. They are primary prevention. And when we talk about money spent to lives saved, and those lives saved are children's lives, which means productivity for a lifetime, that's a huge invest. You get so much more for your money than you do from saving a 70-year-old man with coronary heart disease for living another 5 years. He's already retired, and that sounds very cold and callous as I say that. I think, oh no, I don't mean it that way. But there is very much a benefit to the other.
But it still shows a difficulty, like.
Yeah, I mean, nothing is easy. And if this was all easy, it would already be done. So, yes, I understand where you're approaching the dilemma and stuff. I just don't want people to realize that what they've finally done is they've made things realistic. In other words, the only goal I think that's really hard is the zero obesity. And that's because we've all changed our lifestyles so much. Western eating, lack of exercise, not getting out and doing things. as you get older, that becomes a harder thing to maintain. When you're 22 and you're exercising and playing sports all the time and doing things, it's natural and stuff, but it becomes more of it becomes something you have to work at as you go along through life.
Okay, that's actually more understandable.
Yeah.
I think, doctor.
You're welcome. You're welcome. Mohammed, one last question? Our hand was just still up.
No, doctor, thank you.
Okay. Well, guys, I just took roll about 2 minutes ago. I'm going to stop the recording now. And I hope you all have a lovely week. I will see you next Monday. And we will finish out, inshallah, as you will say, SDGs. Okay? Bye.
Thank you, doctor.
Thank you, doctor.
Thank you, Doc.
Thank you.
Thank you.
Thank you.
Have a good week.
Bye. Goodbye, doctor.
Bye. Goodbye, doctor.